All right.
We have our last case to present, Dr. Chadi Alraies. Would you please come up and...
Yeah, thank you. Yeah, I am here. So I'm a second-year intervention fellow at MedStar, so they left it to the end, so the panel doesn't have time to hammer me with questions. So I'm presenting a case called the rare complication of a safe procedure. I have no disclosure, but I have to say, going forward, everybody should have a social media disclosure and have that on your biography and make sure your opinion is your own. If you agree with me, thank you. If you don't, thank you for the follow. Anyway, 67-year-old white woman with hypertension, AFib, and severe MR. She referred to the cath lab for coronary angiogram prior to her surgical MVR. She was on apixaban, metoprolol, lisinopril, and Zoloft. Coronary angiogram was done via right radial artery. Post-procedure, TR band applied for hemostasis. And that's the procedure itself. However, 2 hours later, the MD was called for the floor from the nurse saying that there's a small hematoma at the radial axis site. Prolonged application of TR band for 2 hours was recommended, and also they applied another TR band on top of the first one, more proximal to the stick point. At 7 p.m., TR band was removed, and patient was given her night dose apixaban. 5 a.m., patient complaining of sharp pain and numbness in the right hand. This is the only presentation you're not going to see any angiograms. So how many in the room do radial? Yeah, that's majority. That's great. So at least I have some audience here. This is her physical exam when we first looked at the hand. This is ulceration of the skin. This is corresponding to the balloon of the TR band as well as a swelling hematoma. Similarly, if you get more a straight shot, this is a pulsating mass. So what do you think is this? Who says it's hematoma? Okay, good. So great. I think I'm done here. We did the ultrasound just to make sure everything's completely kosher and we have the right diagnosis. So we did the right radial. This is a mid-radial. It's more proximal to the artery. On the left panel, the flow is fine. Velocity, as you see here, is normal. On the right side, this is a cross-sectional from the hematoma. However, this is a Doppler. This is the radial artery on the right side, and there is a high-velocity jet going through that small opening to the pseudoaneurysm that everybody pointed out. So at this point, velocity again compromised distal to the stick. So you can see here there is a neck that goes from the radial artery to the pseudoaneurysm. There's some thrombosis lining up here mildly on this wall, and also the pain was excruciating when we pushed on the ultrasound probe. So at this point, what do? Apply TR band 2 more on the sand. Okay, anybody say that? Nobody. Stop apixaban. I think it's too late. I mean, we don't have the reversal in our hospital. None of this one. Cardiovascular surgery. Okay, few. Thrombin injection. Sorry?
Just put it in a sheet more proximal and make it like a covered stent. And then it will seal off over 24 hours.
From the other side?
From more proximal. So if you have the pseudoaneurysm is up here,
yeah.
Just go more distal.
Distal. Get an access.
Put the new sheet in.
Yeah.
It basically acts like a temporary covered stent. The pseudoaneurysm will clot off. And then
right.
Hopefully God, you don't get a new pseudo on your new.
Exactly.
Probably going to need decompression.
Yeah. So surgery, basically, fasciotomy or something. Right. I don't want to hold you from lunch, so I'm going to keep going forward. So what we did is, actually my staff, what he did, is 21-gauge spinal needle directed to the neck of the pseudoaneurysm. And this is one of the strongest messages from this case, is to direct the needle toward the neck. And the reason why is you want to have the thrombin injected where it's the highest velocity going through. So you want to inject at this point here. Let me go back in a minute. Here. You have to start injecting slowly the thrombin, few units at this neck. The reason why, when it's highest velocity, so it push it away from the artery, and that technically can prevent thrombin to going into the radial artery and causing distal embolization. Versus if you inject it here, this is again a theory, is if you inject it here, probably the thrombin will swirl and eventually go through that opening. So eventually we injected that slowly. I think it was really 2 millimeter probably every 2 minutes, and then we just pushed right 3 millimeters through that cavity, and that was able to give us this big clot here. The pseudoaneurysm was almost completely sealed, and the access from the radial artery to the pseudoaneurysm was secured. Ultrasound, the long axis view, as you see the thrombin injection site marked by the arrow. The pseudoaneurysm doesn't have any injection, and the thrombin did not dislodge the radial artery. But in order to make sure the right pulmonary artery is also patent, we did more distal ultrasound to make sure the flow and velocity is intact, and indeed it was normal. And the patient kind of didn't complain of any pain, but at the same time, you always pay attention to the finger and fingernails to make sure there is no blue finger as a sign of distal embolization. So NUAC held was for her for 2 weeks post-thrombin injection, and 1 month the pseudoaneurysm was resolved on ultrasound, as well as the ulceration of the skin is resolved. The surgeon was there standing, watching, impressed, and he just left. Great. Thank you.